Hello, can you hear me now?
Yes,
Okay, that's great. So today we are going to start our pathology, and the first things which we are going to discuss in pathology are congenital heart diseases, right? Congenital heart disease. Okay. So the first one which we are going to discuss is transposition of great vessels, TGA, right? So if you guys remembered, I just told you something about endocardial cushions. Can anyone just tell me what are endocardial cushions? Endocardial cushion cells. Yes, anyone? Hello? Hello? Am I
yes,
audible?
yes, you are. Yeah,
Yes, so can anyone just tell me about endocardial cushion cells?
it's a cell that migrates from neurotube and divide uh, for aortic and pulmonary vessels.
Okay, so we discussed they are basically your neural crest cells, and they are going to migrate into the heart, giving you a structures called endocardial cushion cells, right? And those endocardial cushion cells are going to do a lot of things in your heart. Like we discussed, once you have these endocardial cushion cells, they're going to help you make your, you know, aortopulmonary septum. They're going to help you make some components or some parts of your interatrial septum, some parts of your interventricular septum as well, right? So they are basically your endocardial cushion cells, which are derivatives of your neural crest cells. Okay. Okay. So we discussed that the aorticopulmonary septum is going to be formed by these endocardial cushion cells. So if you guys remember, we discussed two cases that endocardial cushion cells are first going to make the septum called as aorticopulmonary septum, which is then going to divide it into individual aorta and pulmonary artery, right? Then what happens? This septum is going to spiral, right? So as the septum gets spiral, the spiraling of the septum is going to then make your proper aorta and pulmonary artery. That is, aorta is then going to arise from your left ventricle, and pulmonary artery would then arise from your right ventricle. Okay, we discussed that. So we discuss first of all, it's going to make a septum. Then it's we are going to be having a process of spiraling, and after the spiraling, then your aorta is going to rise from your left ventricle and pulmonary artery from your right ventricle. So if we have failure of spiraling of a aorticopulmonary septum, that's going to result in a pathology called transposition of great vessels. And as we know that if we do not have spiraling, so in that case, your aorta is going to arise from your right ventricle, while your pulmonary artery would arise from your left ventricle. So aorta is going to, the deoxygenated blood is going to enter to the right side, then it's going to move through the aorta and systemic vessels, and again it would just come. So this circuit is going to be having entire deoxygenated blood. Remember, deoxygenated blood. Am I right? While the circuit at the left side, from which you have arising, from which your pulmonary artery is arising, it will be having oxygenated blood. So you can see that the blood from the lungs are going to enter into your left heart. Again, they are going to enter into your pulmonary artery, and in this way you have your lungs. In this way you are going to be having oxygenated blood in this circuit. So you can see we have two individual circuits which are being formed on the right side and on the left side. On the right side we're going to be having deoxygenated blood circulating, and on the left side we'll be having the oxygenated blood, which is going to keep on circulating. So you can see if even you are giving 100% oxygen to this baby with a condition that's transposition of blood vessel, it won't improve, because as you're getting oxygen into the lungs, you're further oxygenating, this pathway, which is of no use, because we need oxygenated blood to be here in the systemic circulation in order to improve cyanosis. Is it clear? Hello?
Yes,
Okay. So the first Okay, so in the question variant, you are going to see that we have an individual, a baby, he's cyanotic in even 100% administration of oxygen isn't improving the cyanosis. What should be your first diagnosis in your mind? That's going to be transposition of great vessel. Is it clear? So what's going to be the first line management of this baby? What do you think?
Uh, heard obstructive lesions.
Sorry?
Sorry, can you say again? Can you say again the
A
question?
baby with this condition having transposition of great vessels, what's going to be the first line management for in order to improve this cyanosis?
Ah,
Open the ventricular septum or
Okay.
just
So
arteriosus.
keep the shunts open, right? So
Mm.
we have two shunts, if you remember. That is basically your foramen ovale, if you remember, and the other one is basically your ductus
septum.
arteriosus. Okay, so interatrial septum, right? So
Mm,
keep the shunts open. As we are keeping the shunts open, so now the oxygenated blood is getting chance to enter into your deoxygenated. So you'll be having mixing of oxygenated blood from this side into your systemic circulation. So as we are getting oxygenated blood in the systemic circulation, it would improve the cyanosis. So either you can keep the ductus arteriosus open or the foramen ovale. So in the question variant, they're going to tell you that increase the foramen of, increase the foramen size of your ovale. So if you're increasing the foramen size, so now you'll be having a lot of chance to get the oxygenated blood into your systemic circulation and improving cyanosis. Is it clear?
yes.
And the long-term treatment is surgical correction for that, right? So what would be the chest X-ray finding of a baby having this condition? That would be egg on string appearance. Egg on string appearance. What do you mean by egg on string appearance? As you can see that you do not have proper big arteries arising from the proper heart chambers, so it would result in a thin mediastinum. A thin mediastinum. So you'll be having conditions somehow like that. You have a thin mediastinum from which your heart is arising. It's going to be resembling as egg on a string appearance. Is it clear? Okay. Hello.
Yes,
Yes, yes.
So this was all about transposition of great vessels. Do you guys have any questions? And and why is this? What triggers this pathology? That's failure of aortopulmonary septum to spiral. Okay, so this is also going to be your word MCQ, and this is also going to be your word MCQ. To keep the shunt open, that's going to be the first line management of this condition, right? Egg on string appearance, just go for tetralogy. Okay, just go for TGA, transposition of blood vessel. Cyanosis not being improved by administration of 100% oxygen, just go with TGA, right? Hello.
Yes, yes.
Okay, perfect. So next pathology which we are going to discuss is TOF, that is tetralogy of Fell, right? So we
Hmm.
are going to be having four conditions present in this pathology, right? The first one is that we are going to be having something called, yes,
The
overriding of aorta,
writing of aorta.
overriding of aorta. The second thing which can worsen, if you know, if the second thing which is your pulmonary stenosis. So if we have a lot of, a greater amount of stenosis of your pulmonary artery, at a pulmonary valve, so we'll be having worst case of TOF, which I'm going to discuss in a bit, right? The third thing
Yes.
is that if we have pulmonary stenosis, so the right ventricle is going to become
Hypertrophy. Hyper,
hyper. And the fourth thing is we are going to be having VSD in this condition, right? So
yes.
let me just draw the entire picture. So if this is your heart, first of all, okay, the right ventricle is going to become hypertrophy. The pulmonary artery is going to be stenosed, and normally aorta should arise from here, right? But we have overriding of aorta, that is aorta is also going to arise from the right ventricle as well, right? So if you can see, we have stenosis of your pulmonary artery. So what this stenosis is going to do with the afterload, right-sided afterload, right ventricular afterload.
Decrease?
The right ventricular afterload increase because we have stenosis. And as we increase the right ventricular afterload, we already know that whenever the afterload increases, the heart is going to lay down more muscles. It's going to lay down more muscles. It's going to become hypertrophy. Which type of hypertrophy are we going to see? That's going to be concentric hypertrophy. Is it clear?
Yes.
Okay. So that make a sense that we have stenosis, pulmonary stenosis, which is going to lead to right side hypertrophy. Overriding of aorta, aorta being coming out from your right side. And another thing, we have VSD. So we have a defect present here, right? So we have a VSD, right? So you can see that if, okay, so let's just discuss this case. If right ventricle is hypertrophied and we have pulmonary stenosis, it means the deoxygenated blood entering to the right side, if we have a greater degree of stenosis, so instead of getting it into the pulmonary artery and into the lungs, the deoxygenated blood is going to enter into aorta, leading to cyanosis. Does that make sense?
Yes, yes.
Okay. So for that case, and a baby having this condition, having cyanosis, so the mother is going to tell the baby to squat down, right? And as the baby squat, as he sits, cyanosis is going to be improved. Why? Because we discussed, as we are squatting, so what happens? The afterload increases, right? Afterload to your aorta increases. Does that make sense?
Yes.
So if I'm increasing afterload here, now the blood won't move through the aorta. So basically the blood is going to be shunted here again back. A lot of blood is going to build up. And as we have a lot of, afterload here due to squatting, so the blood is going to enter into pulmonary artery and it can get oxygenated in the lungs, entering back into your your left side. And this way you can get some oxygenated blood, which can enter into systemic circulation, improving your cyanosis. Is it clear?
Yeah.
So the baby is going to become cyanosed when he's, breastfeeding, right? Or when he, for a certain period of time, if he stops his breath, because as a baby is breastfeeding, so at the same time, or whenever he cries, right? So whenever a baby cries, or whenever he's, baby is breastfeeding, the main thing here is that, actually we are making our lung hypoxic because during breastfeeding or during crying, baby cannot breathe. Baby stop breathing at that small period of time. So as the baby is not breathing for that small period of time, at that small period of time, we are getting hypoxia, right? Hypoxia within the lungs. And as we are getting hypoxia in the lungs, so what would happen as a result of that? As a result of that hypoxia, we know that whenever the lungs get hypoxia, we are going to be having vasoconstriction, right? We are going to be having vasoconstriction in the lungs. And as we are having vasoconstriction in the lungs, the afterload increases. So as the afterload here to the pulmonary artery would increase, right? So baby is stopping his breath for that little period of time. Does that make sense? Making a hypoxic kind of situation, right? So during crying, breastfeeding, we are making hypoxic environment in the lungs of a baby, and as a result of that, the blood is going to shunt and it's going to move into the aorta, the deoxygenated blood, worsening the cyanosis. Worsening cyanosis. Does that make sense? Hello? Hello?
Yes, yes.
Okay, does that make sense? Hello?
You can repeat it a bit.
Okay, do you want me to repeat?
Yes,
Yes.
please.
Okay, if we have a baby and he is breastfeeding or when he is crying, so what happened as a result of that? For that brief period of time, whenever baby is breastfeeding, he can't take breathe while he's feeding. Whenever baby is crying, he stop his breath for for some time. That's going to make a hypoxic environment in the lungs. Am I right?
Yeah.
And we discussed whenever we have hypoxia within the lungs, it's going to lead to vasoconstriction of the blood vessels there. In order to shunt the blood towards more ventilated area to get oxygenated. Is it clear?
Yes.
Hello?
Yes.
Hello? Okay, so as we have
I can
vasoconstriction
hear
there,
you.
as we have vasoconstriction due to hypoxia whenever a baby is breastfeeding or crying, what happened to afterload if I'm vasoconstricting all of the blood vessels in the lungs?
Increase.
Afterload
Increases.
would increase. So it means that the afterload to pulmonary artery increases. So if afterload is increasing, it means that the blood would just shunt back into the aorta, the deoxygenated blood,
Yes.
worsening cyanosis, right? And for that, the mother is going to tell the baby to squat down. As the baby squat down, what would happen as a result of that? Yes, afterload to the aorta is going to increase. So as the afterload towards the aorta increases, again we are going to shunt the oxygen, the blood to move into the pulmonary artery, into the lungs, get oxygenated. So that oxygenation is going to improve your cyanosis. Is it clear?
Yes.
Yes.
Okay, perfect. So you can see. Okay, let me just ask you a question, and you guys have to think and just tell me. It's one of your reward MCQ. Okay. For example, if I keeps the shunt, okay, for example, if I keep the ductus arteriosus open, would it improve cyanosis? Yes. What do you guys think? Hello, anyone?
Hey, come again with a question.
Okay, so my question is that if we are just keeping the ductus arteriosus open, if we are
Okay.
keeping the ductus arteriosus open, would it improve the cyanosis?
Yes.
Yes, I think it will improve the sinuses. Yes.
Why?
Mix it up.
Because now it's a shunt right to left to right.
Sealed
Mm.
coat.
Because if the shunt is open, so now again this deoxygenated blood in aorta can get a chance to enter into
Yes.
artery and get oxygenated in the lungs. And as they
Mhm.
get oxygenated in the lungs, oxygenated blood into the heart is going to improve the cyanosis. Is it clear?
Yes.
Yes.
Okay,
Yes.
okay, perfect. So the next pathology which we are going to do, okay, so this was all about pathology of fellow, right? Okay, so the squatting is going to increase the systemic vascular resistance, which is going to increase the afterload, which is going to improve the cyanosis, right? Okay, so let's discuss our next topic, that is Epstein anomaly, right? Epstein
Yes.
anomaly. So what is Epstein anomaly? Yes, please.
Mm.
Is it tricuspidal valve disease?
What's that?
It's a tricuspid valve disease.
Okay, perfect. Associated with lithium
Yes.
exposure. So to which individual do we give lithium? Those who have bipolar disease. We basically give lithium, right? So lithium can cause a lot of problem. They can cause hypothyroidism. They can cause nephrogenic diabetes insipidus, which we are going to discuss in detail. And it can also cause Epstein anomaly. So what is Epstein anomaly? If this is your heart, so what this tricuspid valve is going to do, it's going to move downward here, the left ventricle, just like that, which is also known as, if the tricuspid valve is moving down, so you can see it's basically going to cause arterialization. It's going to cause arterialization of the ventricle. You can see it here, right? So as this valve is moving down, it's called atrialization of the left ventricle. So your left ventricle is becoming atrialized. It's becoming an atria. Why? Because the tricuspid valve has been pushed downward. The atria size have been improved, which can lead to regurgitation as well. You know, the blood from the ventricles can enter back into the atria. So this is basically called as Epstein anomaly, right?
Mm-hmm.
Is it clear?
Yeah.
Okay, perfect. So
It's
we have another pathology, that is VSD. We have discussed VSD in detail. You guys are going to be telling me what is VSD. Yes,
ventricular step defect.
that's going to be your ventricular
Step
septal
defect.
defect. Okay. So in this ventricular septal defect, what happens? The blood from the left side of the ventricle is going to enter into the right side of
Right.
your, right? And we
Mm.
discussed, if the defect size is small, what would happen to the intensity of murmur? Intensity of murmur would increase. If the defect size is bigger, the intensity of murmur will be less. Which heart, heart murmur associated with VSD? Yes,
Polysystolic.
that's a hollow systolic murmur. And where are we going to auscultate this murmur? Yes,
It is fourth intercostal, like where it is tricuspid valve.
that's left lower tunnel border, right? So there
Yeah.
we are going to auscultate this murmur, right? And we discussed, okay, so for example, if we have left to right shunt, it means your right ventricle is going to experience a lot of blood, right? A lot of load, right? So with time, like with a chronic period of time, or with a longer period of time, what happens? Sometimes if your right heart is experience a lot of blood within it, it would become hypertrophied, we know, right? Like concentric hypertrophy. And with a longer period of time, if the ventricular septal defect is not corrected and the right will get hypertrophied, what would happen as a result of that? As a result of that, we can get a reversal of shunt. So whenever we are having left to right shunt, we won't be having any hypoxia there, because we are mixing, in left to right shunt, we are mixing oxygenated blood into the deoxygenated blood, which won't cause any cyanosis, any hypoxia, But whenever the right ventricle become hypertrophied, the shunt is going to reverse. And as the shunt reverse, what would happen? Now the blood is going to move from the right ventricle into the left ventricle. Is it clear?
Yes.
Okay. So as the blood is moving from the right ventricle into the left ventricle, now we are mixing deoxygenated blood into oxygenated blood, and that can cause hypoxia, right? Okay, and this reversal of shunt is basically called as Eisenmenger syndrome. Is it clear? It's called Eisenmenger syndrome. Is it clear?
Yes.
Hello.
Yes.
Yes. It's
Called, so the reversal of shunt is called Eisenmenger syndrome, right? Which can lead to right-sided heart failure as well because right side is getting a lot of load from the left side. Reversal of shunt is Eisenmenger syndrome. Perfect. Then we have atrial septal defect, and we discuss atrial septal defect in a big detail, right? Okay. Are we going to have wide fixed plate of S2?
Sorry, can you say again?
In atrial septal defect, if we have ASD, will we be having a wide fixed split, wide fixed S2 splitting,
Yes, yes.
Yeah.
and why? We discussed it in detail, right? Will we be having paradoxical emboli?
Yes.
Mm-hmm.
Yes, we are going to have paradoxical emboli. Okay, so which study is going to use in order to diagnose ASD? Bubble study. Remember, bubble study. Okay, did you guys remember? We discussed the ostium primum, ostium secundum, and everything. Remember, and it's going to be associated with Down syndrome. Is it
Yes,
clear?
Yeah.
yes, yes.
Okay, perfect, right? So we already have discussed ASD. You guys are only going to read it from your first aid, right? And we just revise it as well. Then we have patent ductus arteriosus, which we also discussed in a big detail, right? So, for example, if this is your heart, this is your aorta, your pulmonary artery, your aorta, right? And we have basically something called ductus arteriosus. Remember, we have ductus arteriosus. Remember?
Yeah.
Okay. So what happens in this ductus arteriosus? Normally we discuss after the birth, it is supposed to close. The ductus arteriosus is supposed to close. But if we do not have proper closure of ductus arteriosus, we can have a left to right shunt. That is, we know that after birth, the left-sided pressures are really high, right? So if the left-sided pressure are really high, the blood is going to flow back here. It's going to be a left to right shunt. Okay, which murmur is going to be associated with patent ductus arteriosus?
Esto,
Which murmur?
esto,
S2 is a murmur?
as.
Missionar
Sorry, which murmur?
machine.
Continuous machine.
continuous machine. More. Machine like.
Yes, machine like murmur, right? So
Yes.
that would be continuous, that is auscultated both in your systole and diastole, this machine like murmur, right?
Ye-
Okay. How do we close this murmur? By administration of NSAIDs. Remember, especially which one? Indomethacin.
Mm-hmm.
Okay. Indomethacin is going to lead to closure of your ductus arteriosus, and high oxygen tension in the reverse direction is also going to close this murmur, right? So it can lead to lead cyanosis as well, because again it can lead to Eisenmenger syndrome if you have a lot of blood coming into pulmonary artery. Again, the right ventricle can hypertrophy, and as it become hypertrophy, it's going to exert large forces which can reverse the shunt, and it can you know lead to Eisenmenger syndrome. But remember that ductus arteriosus attaches to which part of your aorta? One of your UWorld MCQ. Ductus arteriosus attaches to descending aorta, right? And descending aorta basically supplies your lower extremities, right?
mhm.
It supplies your lower extremities. So as we have reversal of this shunt, so the lower extremities are going to be having hypoxia, right? Differential hypoxia, especially seen in your lower extremities. Is it clear?
Yeah.
Okay, perfect, right? Okay. So we discussed Eisenmenger syndrome. That is, that whenever we have uncorrected VSD and ASD, left to right shunt for a longer period of time is going to lead to reversal of the shunt, as we discussed in detail, right? That's going to be your Eisenmenger syndrome. Is it clear? Hello.
Yes.
Okay. So the next topic which we are going to discuss is coarctation of your aorta. What is coarctation of aorta? For example, if this is your heart and this is your aorta. So what happens in coarctation of aorta, that we are going to be having nerving of your aorta, right, at some point. Okay. So if this is your ductus arteriosus, so we can have coarctation or thinning of your aorta just before your before arising your ductus arteriosus, right, or the ligaments, right? The ligament, whenever the ductus arteriosus close, is going to make a ligament. What's the name of the ligament?
Ligament anterioris.
Ligamentum arteriosum, right? So just before ligamentum arteriosum, if we have narrowing of aorta, so we know that ascending aorta is already going to supply your upper extremities, right? Upper extremities. So if I have stenosis here, it means that blood is going to pool here a lot, right, from your heart, and we are going to be having a lot of blood, in your upper extremities, which is going to lead to upper extremities hypertension. Does that make sense? Hello.
Yes.
Yes.
Okay. It can also be associated with bicuspid aortic valve, right? So hypertension in upper extremities is really important factor, which is going to be seen here in coarctation of aorta, right? Hypertension in upper extremities. And another thing, if aorta is basically stenos here, like here, you would be having less supply of your blood, right? So the lower extremities, especially, we discussed that this is going to be descending aorta. So if you compare the the blood pressure in the lower extremities, that's going to be really less, because less blood is reaching to descending aorta, which is going to feed your lower extremities, and a lot of blood in the ascending aorta portion, which is pulling back, making a lot of pressure. So upper extremity hypertension is going to be seen. Is that clear?
Yes.
Hello. So we discussed that we can also have the weak or claudication in the lower extremities, as the lower extremities are getting less blood supply. So with time, what can happen, the lower extremity can become hypoxic. As we are using them, it can become hypoxic, right? So another thing which you should just keep in mind, like this is your descending aorta getting a very less blood supply, and ascending aorta have a lot of blood there, right? So we have some collaterals as well, some collateral circulation, right, which basically bypasses this stenosis or this closed part of your aorta, right? Hello. So what are these collaterals? Remember, these are basically the blood vessels. These collateral circulation, these are your intercostal arteries, right? Intercostal arteries. And these intercostal arteries basically run in parallel with your ribs. They run in parallel with your ribs, right? So it means that if we have less blood here, why do we have less blood in the descending aorta? Because we have coarctation, before the ligamentum arteriosum arises, right? So, but we have another pathway through which the blood can flow and it can enter into descending aorta, that is intercostal arteries running in parallel with your ribs. It means that in the collateral circulation, we'll be having a lot of blood then, right? Because the blood would try to reach through this collateral into your descending aorta. Does that make sense? Hello?
Yes.
Hello?
Yes.
Hello?
Yes.
Okay. So these the costal arteries are going to be having a lot of blood. And whenever we have blood in the arteries basically pulsate. We know that, right? So the chronic pulsation of these arteries, these intercostal arteries, would lead to erosion of your ribs. the ribs would become eroded, right? So if these are your ribs and these are the blood vessels having a lot of blood, they are continuously pulsating. So the rib is going to become eroded, resulting in notched ribs, right? Notched ribs. Is it clear? So we are going to be having notching of ribs. Okay. So rib notching on X-ray is characteristic finding of your coarctation of aorta, right? Since we know that we have a lot of blood, blood pressure in the upper extremities, which would feed your brain as well. So if you have a lot of, you know, hypertension in the blood vessels which are feeding your brain, what would happen as a result of that? As a result of that, we'll be having increased chances of getting what? Of getting berry aneurysm. So what is berry aneurysm? What is aneurysm, by the way? Hello. What is aneurysm?
Aneurysm is a widening of aorta.
Perfect.
Not only aorta, it's
Not
any
all.
area.
It's a pathological dilatation of your blood vessel, right? So it's a pathological dilatation of your blood vessel, right? So as we are having, and one of the risk factor of aneurysm, which we'll be discussing in aortic aneurysm, is hypertension, right? Okay, we'll be discussing that in detail. So if you have, a lot of hypertension in the blood which are supplying your brain, it lead to aneurysmal dilatation? Yes. Hello.
Yes, yes.
Yes,
Yes,
yes.
it can lead to berry aneurysm. So we'll be discussing what is berry aneurysm. Basically occurs in anterior communicating artery, which we'll be discussing in our neurology section, right? So if you guys want to speed up your journey, so I already have added all of you guys into the marathon, right? Right, and we are about to start our CNS module there, right? In a proper detail and everything, right? So don't miss to just do your CNS along with. Still, we are going to revise it in this session, but the thing is that you have to boost up your studies, right? So it would be really easy. Like if I just started teaching everything, it would just take a lot of time, right? So from now onwards, I'm going to divide the simpler topic. I'm going to give you tasks to do that by your own, like hypertension, which is going to be your task for tomorrow, right? So in this way, we can just cover up a lot of things, right? And just also try to follow the marathon sessions as well. Okay, is it clear?
Yes.
Okay. So next thing which we are going to discuss is persistent pulmonary hypertension of newborn.
May I have a question?
Yes, please.
Can you please explain the true and false aneurysm?
The true.
True and false aneurysm.
Okay. So actually we have that's basically a false lumen and so we do not have a true and false aneurysm. We can have false lumen, which we are going to discuss in our aneurysm in detail, right? But remember one thing: whenever you have the concept of true or false in any condition, you know, like for example, we'll be discussing a concept of diverticulum, right? Diverticulum. Do you know what is diverticulum? Hello, hello.
Good.
Diverticulum is basically an outgrowth, right? An outgrowth. So, like for example, we'll be discussing something called Meckel's diverticulum, right? Meckel's diverticulum. We have Zenker diverticulum. In our GIT, we're going to discuss it, right? So let me just give you an overview of what true and false basically means, and you can just apply this concept here, right? So basically, Zenker diverticulum occurs in our upper esophagus, and that's a false diverticulum, right? And Meckel's diverticulum is a true diverticulum. So we have three layers of our GI tract. We have our mucosa, serosa, and adventitia, you can just simply say, right? So whenever we have a diverticulum and in which all of these three layers have outgrowth, like all of these three layers, in that outgrowth in the medial diverticulums, all of the three layers would be pushed outward, making that outgrowth called Meckel's diverticulum, right? So that's a true diverticulum. And what's a false diverticulum? That is a Zenker diverticulum, an example of false diverticulum. That these two layers, the serosa and the adventitia, are going to be intact, while the mucosa is going to be moving out and making that false diverticulum, and the mucosa is basically going to tear these two, they're going to tear these two layers and making that outgrowth Zenker diverticulum, which is a false diverticulum. So true means whenever all of the layers are involved, and false means that a single layer is involved that is tearing through the other layer. That's a false, right? So
Yes,
if,
yeah. It means that like in the arteries wall, like intima that has three layers,
yeah,
intima, media, and adventita. Yeah,
yes.
yeah.
So if all of them are getting, you know, aneurysm, that's going to be a true aneurysm then, right?
Okay. Mm-hmm.
If only the inner layer is tearing the other parts and making a dilatation, there's going to be a false aneurysm then, right? So this is basically a general concept of true and false, right? Okay. Hello.
Yes, yes. Thank you.
Okay. So this was basically the concept of true and false diverticulum. The next thing which we are going to discuss is persistence pulmonary hypertension, PPH. What do you mean by persistent pulmonary hypertension? That's really important. Okay, it's a pulmonary hypertension, by the way, right? Okay. So remember, sometimes what happens that the baby, whenever the baby is, is getting birth, so sometimes the meconium of baby can, the baby can aspirate the meconium, right? Aspirate the meconium, right? So what is meconium? Meconium is basically the first stool which a baby passes, right? That's a meconium. Sometimes baby can aspirate the meconium and it can enter into the lungs, right? Hello.
Yes.
So, for example, if the lungs get meconium there, the first stool of baby, so we'll be having hypoxia there, am I right? Because now the oxygen cannot enter into the lungs, it cannot cross the alveoli to get into the blood. Why? Because we have a big bulk of meconium there, right? Hello.
Yes, yes.
So, if we have that big bulk of meconium, it means that the baby is going to be having hypoxia within the lungs. So as the baby is getting hypoxia within the lungs, we discussed that hypoxia is basically followed by vasoconstriction. Vasoconstriction of blood vessels. Am I right?
Yes.
Okay, so we are going to be having vasoconstriction. So for example, if this is the baby's heart, this is his pulmonary artery and feeding into the lungs, and the lungs have meconium leading to hypoxia, leading to vasoconstriction. So what will happen to the pulmonary artery after load? As they are vasoconstricting, the afterload would increase a lot. Am I right?
Yeah.
Hello?
Yes.
Yeah, increases.
Yes. So if the, okay, similarly like aspiration of amniotic fluid as well can lead to this condition as well. Okay. So this can basically lead to right to left shunt through foramen ovale or ductus arteriosus. Like in the baby, still you can see that the ductus arteriosus and the foramen ovale isn't closed yet, right? And similarly, for example, if this is your aorta, the ductus arteriosus is going to be still open in the baby. So if you're increasing the afterload, it means that the deoxygenated blood is going to be shunting through your ductus arteriosus into the aorta. Am I right?
Yes.
Baby is going to get hypoxia, especially in his lower extremities. Am I right?
Mm-hmm. Yeah.
Okay. Why? Because this ductus arteriosus joined to the descending aorta, and the descending aorta basically feed blood to your lower extremity.
Extremely.
Is it clear? So whenever in the question variant, you are seeing that we have an individual and he is having hypertension in upper extremity and hypotension in lower extremity. What's your diagnosis? Yes, please. Baby having hypertension in the upper extremities and hypotension in the lower extremities. What's your diagnosis?
Persistent pulmonary hypertension.
No,
No.
I just told you, I just made you confused. It's hypertension. That's your coarctation of aorta. That's your coarctation of your aorta. Remember, coarctation is going to lead to upper extremity hypertension and lower extremity hypotension. But if you have a condition in which the upper extremity oxygen saturation is more, while the lower extremities oxygen saturation is less, then what's your diagnosis? Then your diagnosis is going to be your persistent pulmonary hypertension. It means you guys are sleeping. Hence proved. Hello? Hello?
We listen to you.
So you guys are sleeping. You just, mixed up the things. Okay. So it's going to be persistent pulmonary hypertension. If you have, so you have to look towards oxygen and hypertension. Both of them are different, seen in different pathologies, right? Okay.
Yeah.
So newborn is going to be having signs of respiratory distress, tachypnea as he's having some kind of amniotic fluid or meconium there in the lungs, as well as differential cyanosis. Upper extremities are not going to be having enough cyanosis as compared to the lower extremities. Is it clear? Hello? Hello?
Hello.
Okay, so the next topic is hypertension, which is really simple and your task to do, right? It's going to be your task. What is hypertension? What are different types of hypertension, right? Okay, hypertension, urgency, emergency, right? You guys, it's going to be your task for or your homework, which you guys are going to do, right? Okay, let me just give you an overview of hypertension. Whenever the systolic and diastolic blood pressure increase, that's basically your hypertension, right? Okay, so the normal is 120 to 80. If it's more than 120 or more than 180, it's going to be hypertensive urgency. And if it's, hypertensive emergency, if it's even more, right? And leading to end organ failure, right? So urgency won't be having end organ failure due to hypertension, while emergency is an emergency condition having end organ damage, right? So this is your homework. You have to read it, right? Okay, so the next topic which we are going to discuss is really simple. That's going to be your atherosclerosis, right? Okay, your atherosclerosis. So, do you guys have any idea what is atherosclerosis?
Yeah.
Yes.
Like
It's
stuck in the
lesion in the wall of arteries.
Okay. So, as these are your coronary arteries, so sometimes, okay, what's the first event, or the starting event or the triggering event leading to atherosclerosis?
Uh,
That's going to be your endothelial damage.
yes.
Right? As the endothelium get damaged, what would happen as a result of that? Yes, whenever we have damage, we discuss that platelets are going to be coming there, to that region. So whenever the subendothelial collagen is going to be exposed and platelets are going to enter there, right?
Yes.
Hello. Okay, and along with that, we can have some macrophages and LDL accumulation as well, right? So with time, the macrophages can enter there, and the LDL is also going to be there, and the macrophages are going to eat these LDL, giving you something called form cells, right? Form
Yes.
cells. So they're going to, the macrophages laden LDL are going to give you form cells, and these form cells are going to deposit. And as they get deposited, they are going to form these atheromas, right? Atheromas. So atheromas are going to be made whenever we have LDL or macrophage and is laden LDL present there. Okay.
Yes.
What is LDL? LDL are basically your low density lipoproteins, right? So they are
Mhm.
going to make something called a fatty streak first, small streak of fats, having fats, because LDLs are fatty, right, in nature.
Yes.
Okay. And after that, what would happen? As this atheroma grow, upon the top of the atheroma, we are going to be having a small muscle there, which is going to strengthen the integrity of the atheroma. So it's going to strengthen the atheromatous flag, right?
Yes.
Okay. And by any chance, if this atheroma get ruptured, right? If the cap or this smooth layer or fibrous cap get ruptured, so this atheroma can enter, it can move forward, and it can lodges some small vessels of your coronary artery, and they can entirely block the entire length of your coronary vessel. So if the entire length of your coronary blood vessel is blocking, what do you think, which are we going to have? ST elevation myocardial infarction or ST depression? We discussed it. If you guys remember.
Depression.
Gonna be depression.
Depression.
Mhm.
What was your question? Can you repeat the question, please?
Depression, right?
Can you repeat the question? Your question.
My question is that if you have your coronary blood vessel and your atheroma is blocking that coronary blood vessels, so it's going to lead to MI. The MI would be ST segment elevation myocardial infarction or depression.
Um,
If the entire of the blood vessel is blocked.
that would be elevation.
Elevation?
It's infarct.
You said the entire coronary vessel will be blocked. I think it's ST elevation, right?
Elevation?
If the entire blood, yes, that's what I think.
What do doctors, what do you think?
I think it's gonna be depression because it's infarction.
Okay.
Is,
And
is
Dr.
it
Natalia,
full of block?
I think it's depression.
and Dr. Oksana, what do you think?
Is it full block or partial block?
Full block.
When it's full,
Definitely it's elevation.
it's
Yes, Dr. Satoro.
yeah, yeah. Who said that it's elevation when there is like a full black? It's a full infarction.
Yes, Dr. Natalia.
Yeah, I said depression, but I'm thinking because if it will be full blockage, it will be elevation.
I'm just telling you that it's completely blocked.
It's completely blocked, it's elevation.
It's elevation because it's going to lead to transmural infarction.
Yes.
Yes.
Transmural infarction is your
Absolutely.
elevation.
Yeah.
We discussed it in detail. Your entire, layers of the heart are going to become infarcted, right?
Yes.
Yes.
When
Okay.
it's closed.
Okay, so we have these complex atheroma. Sometimes these atheroma can become calcified as well. The dystrophic calcification, we are going to discuss that. Okay, so what can be the complication? Ischemia, infarction, aneurysm, peripheral vessel disease, thrombosis, embolism. It's a thrombus, right? Fatty thrombus, right? Once it just detaches, it can lead to embolism as well, right? Is it clear?
Yes, it is.
Okay, perfect. So the next topic which we are going to discuss is cholesterol emboli syndrome. What is cholesterol emboli syndrome? Just looking towards the name. Can you just please tell me?
It's a cholesterol plaque travel in the system.
Perfect.
After PCI, for example.
Okay, so can I say whenever the atheromatous plaque, move in the large arteries, like especially in the aorta. For example, if it get enters into the aorta, from the aorta it enters into systemic circulation.
Yeah.
It can lead to, you
Embolism.
know, yes, it can become
Yes.
and it can lead to a lot
Embolism.
of problem,
It's
inflammatory response.
complete leads to MI.
It
If
can
it
lead
go
to
to brain, it will be stroke. It
Yes.
will be kidney
that it would lead to
infarct.
stroke.
Yeah.
Yes, kidney infarct, digit ischemia, right? Digital, for example, if it get into your lower extremities and in your digits, right? Your finger digits, it's going to lead to
Yeah. Bluto or libido reticularis.
perfect, right? Libido reticularis as well, right?
Yeah,
Okay,
crystals enter the bloodstream.
so whenever it enters large arteries, aorta, and get enter into, you know, the branches of your aorta, like it can enter into the brain, into the
Yeah,
kidney, into the
kidneys.
liver,
Yeah,
right? Okay, perfect. So that was basically your cholesterol emboli, right? Okay. The next topic which we are going to discuss is arteriolosclerosis.
Sclerosis.
So what is arteriolosclerosis? Do you guys have any idea?
I think it's still plaque formation in the small vessels,
Yeah, affects small
small
arteries.
arterioles. Yes, affecting the arterioles.
yeah,
Okay. So it's not a plaque formation, but yes,
Like,
you're right. Arteriolosclerosis. The small arterioles are becoming sclerosed.
yeah. It's due. It's one of the best, like complication of a diabetes.
Perfect. It is one of complication. Yes. So we have two types of arteriolosclerosis. One is
Yes,
hyaline,
plastic
the other one is
Iron and
and hyaline.
hyperplastic.
hyperplastic.
So
Yeah.
what is hyaline, by the way? So if this is your blood vessel, sometimes we have a protein present in the blood vessel which is known as hyaline protein, right? Sometimes this hyaline protein can just move out of the blood vessel, and it can basically deposit in the blood vessel endothelium, and as it deposits in the endothelium it would lead to sclerosis or thickening of the blood vessels, decreasing
Yeah,
the.
thickening of the
Mhm.
vessels due to hyaline material.
Yes, hyaline material, which is basically a protein present in your blood, right? So it can lead to hyaline arteriolosclerosis, right? And how
Mhm.
hyaline arteriosis is going to, like, how this hyaline is going to enter in endothelium blood vessel? It can occur in diabetes, right? Or hypertension as well, right?
Yes,
Diabetes, we are going to be having something called non-enzymatic glycosylation, right? So the glucose is going to be present a lot in diabetes. We know that, and as a result of that glucose, what would happen? We are going to be having non-enzymatic glycosylation. So what is non-enzymatic glycosylation? Without using any enzyme, the glucose is going to react with your endothelium, and as it react with endothelium, that's going to trigger, the hyaline being coming out and making depositing in the blood vessel, making your hyaline arteriolosclerosis. Is it clear?
yes,
Okay. Then we have hyperplastic as well. What is hyperplastic? Hyperplastic is going to be due to hypertension, right? Severe hypertension.
yes,
What
mild hypertension.
Yeah, with proliferation.
severe? Perfect. So, for example, if this is your blood vessel, you have severe hypertension. We know that whenever we have hypertension, how does the blood vessel, respond to that? The blood vessel wall basically become thick. That is the smooth muscle layer of the blood vessel is going to start proliferating in
Mhm.
order to stand this increase or severe pressure or force, right? So
Yeah.
how do it become thick? Thick, as we discussed, your blood vessel is going to lay down more, more smooth muscle.
Muscle cells.
Right? So as it lay down more smooth muscle cells, these smooth muscle cells are going to be layered in the form of layering pattern, right?
Mhm.
yes,
Like one layer of smooth muscle over other, one layer, another layer over other. So it would just appear as a
Onion skin.
skin
As onion skin.
that is going to be,
Onion skin.
yes, and it can lead to. So we are going to be having a UL MCQ. We just found a guide that you know, this a guy that on a street and he was having an end organ failure. And as we just visualized that, we were having onion skin appearance of his blood vessels. What do you think? What was the cause of his death?
Sorry, can you say again, please?
We were having a guy, he was found dead, right? And as we just zoom in his small eyeballs, they were having an onion skin appearance. What do you think the cause of that is?
It could be as a result of hyperplastic arteriolosclerosis, which is a complication of diabetes. So the patient may have had, sorry, with a complication of severe malignant hypertension. So the patient may have had, uncontrolled hypertension leading to that.
Yes, perfect, right? So he might be having uncontrolled
Can I feel you?
hypertension. Is it clear?
Yes.
Okay, perfect. So the next topic which we are going to discuss next and our last topic on which we are going to spend a little bit time, that's going to be aortic aneurysm, right? Aortic aneurysm. Before discussing that, Dr. Satarov, have you completed your physiology you were?
Not unfortunately.
How many MCQs do you have?
We really didn't do anything yet.
And why is that?
Yeah, we will start today because we had like little bit like personal issues for this reason.
Oh, no problem, no problem. Okay. So we have aortic aneurysm, right? So let's discuss the concept of aortic aneurysm. Everyone know aortic aneurysm is a pathological dilatation of aorta, right?
Yes.
Since we know that aorta is a really big vessel, right? It's a really
That is
big,
correct.
biggest vessel of your body, biggest artery carrying oxygenated blood, right? So if it's so big, it means it needs some small blood vessels to give the aorta blood itself, right? It's a big artery, so it means it needs, small blood vessels to feed nutrients, oxygen to this big artery, right? So what are these small blood vessels which are feeding these big blood vessels nutrients and oxygen? They are called vasa vasorum, right?
Yes.
Serum.
They are vessels of the vessel, vessels of a vessel, right?
Mm-hmm.
Vasa vasorum mean small blood vessel of a big vessel, right? Okay. So remember, whenever we have hypertension, so what happens as a result of hypertension? We discuss in order to withstand hypertension, all of your blood vessels become thickened, right? Hello.
Yes, yes.
Okay. So with hypertension, these small blood vessels would also become thickened, right?
Mm-hmm.
And as they become thickened, it means the lumen size would decrease. It means now it would be really difficult for these small blood vessels to feed oxygen and nutrients to this big blood vessel. Am I right?
Yes, dilatation of aorta.
Yes. So it means that if the big vessel aorta isn't getting enough blood or nutrients, it would become weak,
Mm-hmm.
right? And as it become weak due to hypertension, it's going to be pushed outward, making an aneurysm, right? Is it clear?
Yes.
Right? So whenever we have decreased nutrient supply to your aorta, basically, it's going to lead to weakening of your aorta. And as your aorta get weakens, it would lead to pathological dilatation, which is basically your aortic aneurysm, right? So for example, if aorta get dilated at the root, so won't it lead to some regurgitation? Hello?
Yeah,
It's going to
hello.
lead it's going to lead to aortic regurgitation, right? Am I right?
Yeah.
It's going to lead to aortic regurgitation. Why? Because the aortic valve casts are going to move really apart from one another. And as they move apart from one another, now the blood would just flow back into your left ventricle, which is going to lead to this problem. Okay, so we have aortic aneurysm, and the only cause of aortic aneurysm is going to be hypertension. Some other things can also lead to aortic aneurysm. For example, the Marfan syndrome. Remember, we discussed Marfan syndrome in detail. We have fibrillin that is going to be acting as a gluing or cementing particles between your connective or collagen. If you do not have that, you're going to be having loose kind of, um like we're going to be having a loose collagen. Again, the loose collagen is going to lead to dilatation. Am I right?
Yes.
Okay. The tertiary syphilis itself can lead to aneurysm. So what is tertiary syphilis? Treponema pallidum, right? So tertiary syphilis basically directly infects your vasa vasorum, right? Vasa vasorum. If the vasa vasorum are directly getting infected, so what happens as a result of that? It's going to be obliterated, right? Okay, so in fact,
Yes.
the vasorum, again, the idea is same. We won't be feeding this big blood vessel, and as we aren't feeding this big blood vessel, okay, sorry, it's Azan here, right? Hello, hello. So I
Hello.
have to. Okay, so it's my prayer time, and we have Azan going on, so we'll just continue after 2 to 3 minutes. Okay.
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 Hello, can you hear me?
Yes.
Yes, we can hear you.
Yeah.
Okay. So we were discussing tertiary syphilis, right? So the bug itself can lead to inflammation of your vasa vasorum, and as your vasa vasorum are getting inflamed, what would happen as a result of that? Again, it cannot feed your big blood vessel, that is your aorta, right? And aorta, as a result, is going to become weak. As aorta become weak, again, it can lead to aneurysm. Is it clear? Hello.
Yeah.
Could you repeat it, please?
Okay, yes, I can definitely repeat it. It's your vasa vasorum, small blood vessel, which basically provide nutrients and oxygen to your aorta. Am I right? So if these small blood vessels are getting inflamed, again, as they are getting inflamed, they cannot supply oxygen and nutrients into your aorta. And as again your aorta isn't receiving nutrients, oxygen, it's going to become weak. And as it becomes weak, this weakening can lead to pathological dilatation, that is aortic aneurysm. Am I right?
Yes, that makes sense.
Okay, perfect, right? The last topic which we are going to discuss for today is abdominal aortic aneurysm. So, what is abdominal aortic aneurysm? We have abdominal aorta. Sometimes the abdominal aorta can also pathologically get dilated. That's going to be your abdominal aortic
Mhm.
aneurysm, right?
Yeah.
Okay, but this time the reason or the cause is not going to be hypertension. It's going to be direct inflammation of all of three valves of your aorta, right?
Yeah.
Yeah.
And what
Yeah.
can trigger this inflammation? This inflammation is going to be triggered by smoking, because smoking directly can lead to endothelial damage, and it can lead to ongoing inflammation, right? So you have a UWorld MCQ, they're going to ask you what's the main cause of your abdominal aortic aneurysm. That's a transmural, inflammation of all of the layers. What's the only cause of getting abdominal aneurysm? That's going to be tobacco smoking, right? Men in male and some family history as well, right? So if abdominal aorta is getting inflammation, the valves, it's not getting aneurysm. So what would be the presenting feature? That's really simple. You're going to be having an abdominal pulsating mass because it's have a blood. Whenever the arteries have blood, it's going to be pulsating, right? So we are going to be having anterior abdominal mass, which would be pulsating, right? Which would be pulsating. Is it clear? And if it get ruptured, the rupture can lead to a lot of problem. It can lead to hypotension and hypovolemic shock. Okay. Along with that, acute back pain and resistant hypotension as well. That hypotension won't be corrected easily, right? So the most often is infrarenal, right? Okay. So the infrarenal abdominal aorta can get, aneurysm in most of the cases. Is it clear?
Yes.
Hello.
Hello.
Yes, yes,
Yeah,
that's
the
clear.
most common site of occurrence is infrarenal. Is that what you said?
Yes, infrarenal. Most often infrarenal distribution. Why? Because below the renal artery, the abdominal aorta, the distribution of vasa vasorum is really less there, right? So we have really less, you know, distribution of vasa vasorum. So if it gets inflamed as well as they are having less blood vessels, so both of them are a high triggering, risk factors to get aneurysm, especially in this case, abdominal aneurysm. Is it clear?
Yes, clear. Thank you.
Hello? Sorry?
Hello. We're here.
Yeah.
Dr. Maniza, I can't hear you properly. Do you have any question?
No, everything is clear. Thank you.
Okay, thank you. So it was all for today. Okay, we discussed congenital heart diseases. We discussed, okay, all of coarctation of aorta. We discussed pulmonary persistent hypertension. We discussed atherosclerosis. We discussed arteriolosclerosis. We discussed aortic aneurysm. Hypertension is going to be your homework. So tomorrow we are going to discuss, our dissection, cardiac infarction, and some narrow complex tachycardia, right? So hopefully day after tomorrow we'll be finishing this entire pathology, then we'll be discussing our pharmacology. So just try to wind up your new world task because as I've mentioned, I've discussed this entire new world here as well, right? So most of the concept and since practicing new world is really important because it's going to give you that MCQ sense. You can just gather a lot of knowledge, but since your exam is going to be an MCQ exam, right? You don't have to, you know, lose your MCQs practice skills, right?
Right, thank you.
I already have shared the subscription. Anyone can just open that and they can just start practicing their questions from it. Okay.
Okay, thank you, doctor.
Thank you so much.
Thank you so much. Thank you and have a nice day. Bye bye.
Bye-bye, thank you so much.
Yeah.
Bye.
So much. Have a great morning.